Good evening, everyone. Thanks, API and Team Midas Mukeva sir for inviting us, being a chair for this session. So fever in ICU is always a nightmare. It can be as simple as thrombophlebitis and as complicated as a 2-month patient in ICU and landing up in fever and you have exhausted antibiotics. So just to take it forward, I'll request Balankhe sir to take us through fever in ICU. How do you proceed?
Thank you, Ashwini. I totally agree with you. It's always a nightmare. I'll go one step beyond that. It's a nightmare for the treating physician and delight for the rest of the consultants because they are very happy that they are not managing this patient. There's so many questions to answer and there are no solutions for them. And that's always a nightmare. And the relatives always ask you, अरे वो इतना उसका हार्ट अटैक भी ठीक हो गया, उसका GI बीट भी कम हो गया, उसका स्ट्रोक भी कम हो गया, तुमको फीवर का कारण ही नहीं समझ रहा. It's always a nightmare to really answer those questions and go ahead with some logical, judicious answers for them. As we all know, fever is always a physiological response. It is regulated through pyrogens and through antipyretic pathways, which are these result into alteration in the hypothalamic set point. So this physiological response, like there is a need for dissipation of energy, the physiological dissipation, so the hypothalamic set point changes and you get fever. But the term hyperthermia, although it's interchangeably used with pyrexia, it's not physiological, it is a pathological response which is not associated with changing or increase in the hypothalamic set point. It is related to something else. So it is not pathological, rather physiological, but it's a pathological response. Whenever we need to establish a diagnosis of fever, always a central temperature is recommended. You don't have, but then we usually use peripheral sites like mouth, axilla, because they are very much convenient. For the central measurement of fever, the usual sites which are recommended are urinary bladder, esophagus, and the rectum also. Peripheral thermometers have a sensitivity of 64% and specificity of 96% when it comes to measuring temperature. Now we are talking about the causes of fever in ICU per se. We are not going outside the ICU. And the body temperature 38.6 we consider as normal, but now with the ITSA guidelines they have shifted to 38.3 degrees, which is we had been referring to 38.6 till date. And they have divided this fever into pyrexia and hyperthermia. Pyrexia usually is caused by either infectious causes or non-infectious causes. Non-infectious causes are also many in ICU. You have to always keep in mind that your patient is also likely to have a non-infectious cause of fever. Don't run after the moment there is a spike. Don't sort of go on escalating the antibiotics because they are a rare species and we are losing on them very fast. The infectious causes, pneumonia, the catheter-related bloodstream infections, Monali has already told about catheter-associated UTIs, urosepsis, ventriculitis, meningitis, encephalitis, then surgical site infections, intra-abdominal infections, which will be touched later on, and of course, bed sores, which are not seen but which are most dreadful because it really speaks upon the nursing care of your unit. And if in case bed sore is the cause of fever, it doesn't speak good for the type of nursing care that your unit is providing. Non-infectious causes are many. It may be drug fever, as Ashwini said, thrombophlebitis, mostly the deep vein thrombosis is not, but at times superficial thrombophlebitis is also one of the cause. Acute myocardial infarction, a commonly missed out cause, dehydration, pancreatitis, acalculous cholecystitis, and transfusion-associated hepatitis, or even transfusion itself can be one of the reasons of non-infectious causes of fever in ICU. Hyperthermia. Now, this is one area which is like you get patient who gets fever beyond 103, you start getting blood cultures, you start getting PCTs, you go on doing a lot of investigations, and the reason is somewhere else. It's not infectious. This is like acute traumatic brain injury, subarachnoid hemorrhage, stroke, then endocrinal causes like thyrotoxicosis, adrenal crisis, pheochromocytomas, then multiple drug reactions, then malignant hyperthermia, serotonin syndrome, and neuroleptic malignant syndrome. So the last three from the neurological point of view, then adrenals, and then again the neurology. These are commonest causes of hyperthermia, not pyrexia. Then most of these patients have fever more than 102 in ICU. Most of the episodes, though not all, but most of the episodes in ICU are infectious, and they may be community acquired or they may be acquired in the hospital. Now the trend is like not to utter this word of hospital acquired infection for legal causes, and now people have started using hospital associated infections rather than hospital acquired infections. Community acquired infections are like LRTS, typically the Streptococcus pneumoniae, or multiple viral pathogens like we are getting nowadays in our ICU. And hospital acquired infection, most of the times they are VAPs caused by the ventricular associated pneumonias, and they may be gram-negative bacilli or they may be fungal pathogens. Even UTIs, at times those who are catheterized and don't get a good bladder care are likely to get urinary tract infections from the hospital itself. The UTI in hospital, Monali has stressed on this with a beautiful diagram she had, that it is a result of biofilm formation on an indwelling urinary catheters. Biofilm doesn't allow the antibiotic to penetrate across over the pathogen and therefore allows the growth of pathogen, and more or less it's an MDR pathogen which is going over there. Incidence is very high, almost 40 to 45%, and Pseudomonas aeruginosa, the bacteria which Midas and Ames were growing, they have shown was, what you were showing was more of Klebsiella, but the international literature is still stuck up with Pseudomonas aeruginosa. It's basically the host, the unit which is going to grow something. Maybe the bacterium may change after some time, but commonly Pseudomonas, but Klebsiella, Proteus also are known to cause UTIs in ICU. This infection may subsequently enter the bloodstream, almost 2% of the cases, which may lead to disseminated sepsis, and urosepsis, you know, is very dreadful and life-threatening. Risk factors, usually extremes of age, diabetes, and indwelling vascular catheters like central line associated bloodstream infection. Always see to it your lines are changed after 10 days, not more than 11 to 12 days. You are many a times tempted, one more day and tomorrow I'm going to change it, and then in the evening you get a spike which is not going to leave the patient for long. So always try to see to it that the lines are changed after 10 days or not more than 11 to 12 days. Central nervous system causes like encephalitis, meningitis, ventriculitis, and epidural abscesses. They are also the reasons of fever in ICU. Sometimes the mentation is obtunded, sodium is 125, we try to run behind the sodium, and in the meanwhile we are allowing the neurological infections to go up. So always check for the neck stiffness. In spite of all other parameters of metabolic encephalopathy are there, try to rule out that your patient is not having infection. There is one more infection which is most of the time missed out. Maybe if someone has like the list which has been over, we have missed out on one infection which is missed out in most of the ICUs also, and that is sinusitis. Almost every patient in ICU has a nasogastric tube, and these patients, all of them, most of them do have sinusitis. You try to screen, get their scans done from neck to pelvis, you to get their brain scans, do a CSF, do a PCT. You go on doing investigations, you know this is sepsis somewhere, but sepsis somewhere, and then you end up with a sepsis in sinuses. Take care of that and things will be all right. Unexplained fever through non-infectious causes may be most commonly seen in neurointensive care. This was a study by Rabinston, which nearly 1/3 patients had fever with no identifiable cause other than primary brain injury, which is a very big number. Like 33% of the patients had non-infectious cause for fever. And fever was found to be significantly more in patients with subarachnoid hemorrhage. And that also needs to be kept in mind because it's a prognostic parameter. 50 to 80% of patients of subarachnoid hemorrhage will have fever in first week. Now 80% is a very high number, and we have to also believe that this thing can exist rather than running for the causes of other infective causes. And the cause of fever in subarachnoid hemorrhage is extravasation of blood in CSF, which triggers the febrile response. High fever in subarachnoid hemorrhage itself is an independent predictor of mortality and morbidity. So if you have a subarachnoid hemorrhage without infective cause, if your PCT is negative, the counts are normal and high fever, always try to bring that hyperthermia into a euthermic state because it is known to improve outcomes. In traumatic brain injury, pyrexia in first week is associated with increased ICP, with increased ICU stay, with increased mortality, and finally increased morbidity also. Instituting hypothermia in these patients, although has a theoretical benefit, but has not shown to improve outcomes following traumatic brain injury. So you just have to bring this hyperthermic patient into a euthermic state, and hypothermia has no much benefits in these patients. And rather it can actually lead to increase in rate of infections and a compromise in hemodynamic state. So always keep in mind that traumatic brain injury, hyperthermia needs to be treated, but hypothermia needs to be avoided completely. Acute stroke also is known to have fever, and there are some hyperthermia syndromes which are neurologically, which are seen in neurological patients. Dr. Bhave might be seeing this neuroleptic malignant syndromes in quite a few of your patients. And serotonin syndrome is another group of patients, malignant catatonia, Parkinsonian hyperpyrexia syndromes, and drug fever. So non-infectious causes neuro-ICU contribute significantly to non-infectious fevers rather than the other ICUs. Neuroleptic malignant syndrome is a rare but potentially lethal. So always try to anticipate and accept these patients who are on antipsychotics. This is typically seen with the use of dopamine antagonist, and diagnosis is based on history and physical evaluation. Symptoms are usually seen in 2 to 3 weeks after the exposure of causative agent. The mechanism is not too much known, and sudden reduction in central dopaminergic activity due to D2 receptor blockade is proposed to be one of the hypotheses. These patients classically have severe muscle rigidity, fever, and they have an altered mentation. So this is a triad of rigidity, fever, and mentation, altered mentation. They have very high CPK to the extent that they may have myoglobinurias, and they're likely to have acute kidney injury later on, which may have manifestations of metabolic acidosis. Metabolic acidosis is more because of anaerobic metabolism in the muscles rather than what is being generated from the kidneys. Serotonin syndrome also is seen with neurological and psychiatric patients triggered by the use of serotonergic drugs or overactivation of central as well as peripheral serotonin receptors of 5-HT, 1A and 2A. These symptoms may be due to therapeutic dosing and also due to overdosing. So it's not always that you're overdosing. Even in normal therapeutic dose, you're likely to get serotonin syndromes. It usually begins 24 hours after the adjustment of dosages, and serotonin syndrome is characterized by autonomic hyperactivity, and the rest of the findings are more or less same like neuroleptic malignant syndrome. And interestingly, the serum serotonin levels are normal in these patients. Malignant catatonia also, we have discussed NMS, so there is no need to discuss malignant catatonia. Neuroleptic malignant syndrome can be considered as a drug-induced malignant catatonia. So it's more or less same. And the presentations are also same, except that you may require an ECT in these patients to manage fever or manage hyperthermia. Parkinsonism hyperpyrexia syndrome, again, like with all the D2 receptor patients, any time you try to de-escalate the therapy in Parkinsonian patients, you are likely to have these type of presentations, and the labs will show increase in creatinine kinase, increase in rigidity, increase in metabolic acidosis, and the treatment is, and whatever medicines which you have discontinued or de-escalated, you have to go back to the previous doses to treat these patients. Drug fever is always a diagnostic dilemma every time. It takes several days to subside after discontinuation of drug. This statement is important because many times we feel that if I've come to a foregone conclusion, this is drug fever, I stop the drug, and day after tomorrow I feel, abhi to bukhar gaya hi nahi. It's not going to happen so fast. It's going to take long time. So always keep in mind that if you are anticipating a drug fever, it's not going to go in 48 hours. It's going to take its own sweet time. Multiple drugs have been described, like you can have carbamazepine, phenytoin, phenobarbital, minocycline, allopurinol, nitrofurantoin. So these are some common drugs which we should always keep in mind. The carbamazepine, the phenytoins, the nitrofurantoins and allopurinol. Then there are some altered thermoregulatory mechanisms which can cause drug fevers, and there are some multiple more mechanisms which can cause drug fevers. We can cut short because of the rings which have been hearing on the other side. Lab investigations, diagnostics, routine labs can be done. Cultures, bus culture is a common thing, blood, urine, sputum cultures, catheter trip cultures and CSF findings. Imaging, whatever imagings are available, they can always help you to come to some conclusions. Treatment, because the title was fever, I think we can skip on the treatment part. Just for infections, antibiotics, antiviral, antifungals. For non-infections, again, beta blockers and alpha blockers. For parasympathetic, sympathetic hyperstimulation, which we have missed on non-infectious causes, dantrolene and benzodiazepines. So the take home, I think we can skip this also. Fever in ICU is a tough situation, all of us agree. There is no one who would say it's very easy to handle fevers. A high index of suspicion of hyperthermia syndromes needs to be there all the time. Anytime your PCT is negative, start thinking on hyperthermia syndromes which are there. Injury to brain may be one of the triggers for fever, and maintenance of euthermia, euvolemia, and maintenance of hemodynamics is key to management. Thank you very much.
Thank you so much, sir, for the excellent talk. I think fever is one thing which is next to hypoxia and shock, which an intensivist see in their routine setting, and almost 70% of the patients would have fever. Any questions from the house?
Yeah, Nikhil, great lecture.
Thank you, sir.
How much importance you give to procalcitonin, PCT? That's question number one. And when do you suspect that this patient has antibiotic-induced fever or drug fever in clinical scenario?
Spot single PCT doesn't have any significance, but sequential PCTs really help you to decide escalation or de-escalation. But if your PCT is very high, say 16, 25, 30, then it always, like if your PCT is 2.5 with creatinine on slightly higher side, you have to take with a pinch of salt. But very high PCT, one single sample you can, and all other things which are available to you to discriminate between infectious and non-infectious, then start thinking of infectious if their counts are high and PCT is high and rest of the things. But sequential PCT has a role to play in escalation of antibiotics and in de-escalation of antibiotics. Now there is another term of PCT negative sepsis, where your counts may be very high, like 25,000 or 16,000 or 20,000 leukocytosis, and PCT is negative. And your patient is having fever, he or she is very toxic. Most likely, this gentleman is having fungal sepsis. So your PCT negative sepsis and counts are very high, start with antifungals. And the
second question is drug induced, but normally in patients with pancreatitis, this is a problem which we face. Your patient has counts which are elevated because of SIRS, and then where to draw where the infection is in the second week. So that's a problem where to start antibiotics and...
Procalcitonin, it comes to us from parathyroid, and it's only the bacterial sepsis which starts the triggering and the release of procalcitonin. So whenever pancreatitis goes into an infection, then only the procalcitonin will start rising. But if procalcitonin is 2.5 and creatinine is 1.8, I think still we need to take it with a pinch of salt. But if procalcitonin is very high and you know the patient is deteriorating, then you are tempted to go on with antibiotics.
Drug fever, second question.
Drug fever is like you are exhausted with, it's a diagnosis of exclusion. It's never a diagnosis at the outset Like he comes and someone says drug fever. Usually there are some professors who believe of putting this diagnosis, but it doesn't have any standing. We need to evaluate these patients, come to a very definitive logical conclusion that you don't have anything to attribute to it. And then we have missed out on few slides of drugs which are commonly causing drug fevers. The third, fourth and fifth slides had some drugs. At least our ICU should have list of 10 drugs which can cause fever. If all the tests are negative and your patient is on one of them and continue to have fever, in that case you should start suspecting when you are exhausted with your all diagnostic modalities.
Sir, can I add something to it? Sir, generally drug fever will not cause in a hyperpyrexic state. So it would be always less than. If the patient is in hyperpyrexia, then maybe we are likely dealing with some non-infectious causes, but drug fever would not be part of it. Infectious causes, as Sir has truly rightly pointed out initially, that hyperpyrexia is something which has to be differentiated from pyrexia. So infectious causes are more likely to be there in pyrexic region, whereas hyperpyrexia non-infectious causes. Sir, I just want to ask you one thing, sir. What about the instruments which we use, like humidifier and all? Can they also be responsible for fever in our ICU setting?
Humidifiers, if there is the solution, which is supposed, it is known to transmit infection. So now the concept of moving to dry humidification or dry oxygenation we are moving towards that, so as to reduce the infection part. And what was the second thing you said?
That's it, sir.
And even for like drug cannot cause hyperpyrexia, in that case, all the serotonin drugs, serotonin syndrome is hyperthermic syndrome.
Yes.
So there is a drug
There it
involved.
would be there.
Neuroleptic malignant syndrome, all are antipsychotic related, so drugs are involved. The Parkinsonian plus is all. So there is a very thin line between the two.
So drug fever, generally the patient would be more stable compared to a patient who would be in shock or
Exactly.
something.
So the toxicity in drug fever, the patient very stable and relatives very unstable is drug fever. And as you said, pyrexia, hypoxia and fever, but in hypoxia you have happy hypoxia. In fever there is no happy fever. So that's
So
the
the
big
drug
thing.
fever, yes, patient are stable, but sometimes if you have DRESS syndrome or something, probably you can have
Yes.
unstable patient with drug fever also.
Thank you, sir, for your excellent presentation.
Thank you very much.
Thank you so much, sir.